Hi, I'm Art Caplan. I'm at the Division of Medical Ethics at NYU's Grossman School of Medicine. Many, many years ago, decades ago, I first found out about the idea that came out of England in a nurse, Cicely Saunders, to change the setting in which people die. At that time, most deaths occurred when you were very sick in hospitals, in ICUs. And the idea that came from England was maybe we should set up special areas either within the hospital or sometimes at home, hospice. And in these areas, people who were dying, who had run out of options, for whom there were no more treatments, could be given good palliative care, emotional support, spiritual support as they die. And I think that was a wonderful idea, and it has revolutionized end-of-life care. We have many, many excellent, superb hospice programs. Some are in institutions. My own institution has a very sound and thoughtfully run hospice program. I've had relatives die with great home hospice care. But a hospice institution is decades old, and it's time to take another look at what's going on there. You might think, well, hospice, you're not giving treatments. That's probably not attractive in terms of investment or equity, entrepreneurs who are trying to make money. But on the contrary, hospice is one of the most profitable things you can run because you get a set rate regardless of how much you do. And hospice care takes place sometimes at home, and they don't even require nurses to be there more than, say, twice a month by regulation. You can keep your overhead very low, outsource a lot of the work of hospice to the family members, not nurses or nurses' aides or helpers or providers. And the way the benefits work, you're starting to get benefits going for many, many months before someone dies. A long hospice stay means big profit, and if the patient is pretty stable, few medications and supplies. So private equity is all over this area, buying up hospice chains, buying up home care hospice, looking to make big profits, but not looking to maintain the quality requirements that ought to be there, or to do more than is minimally required to set up and staff hospice. I think there's another reason to worry about hospice. The way in used to be you agreed that you wouldn't take any more treatment, that you would be there, and the reason the setting was set up the way it was and fixed fees were levied for reimbursement was that you weren't going to take any more serious medicines other than pain control. But today we have more and more emphasis on compassionate use. New drugs not yet approved by the FDA might offer a chance to someone who's dying in a hospice setting. I think we have to make room for the possibility that a new unapproved therapy, gene therapy, drug therapy, vaccine for a particular cancer, is something that a hospice patient ought to be able to try without getting bounced out of hospice. If it works, great, then come out of hospice. But don't restrict options so much that a last-ditch effort from this cornucopia of new drugs and new interventions that are popping up are not available to someone because they're in hospice. Get the old rationale, but I think it's time to recheck it. So for reasons of serving the best interests of hospice patients, rechecking the fairness of reimbursement, not overburdening families with care that ought to be provided by hospice programs, making sure that those who are dying are monitored adequately, get the kind of checkups regularly that they merit, not necessarily a few times a month, having somebody come in to look at them, and making sure that in today's age, if something new and exciting appears but isn't yet approved and wasn't available when they went into hospice, they should get their chance too. Hospice remains an admirable concept, a great addition to managing and producing better death for each one of us, but I think it's time to upgrade. I'm Art Caplan at the Division of Medical Ethics at NYU's Grossman School of Medicine. Thank you very much for watching.